Good evening, everyone. Thanks for logging in on time. We have everybody on mute for this evening, so there will be a Q&A session towards the end, along with the discussion. If this is your first time to Zoom, so please share your questions via the Q&A box, which you'll find at the bottom of your screen. Let us know if you have any technical issues, and we'll try to help you with it. So welcome to tonight's VIVA Asia Education webinar on PET-CT in pediatric oncology. My name is Teresa from the VIVA Foundation for Children with Cancer, and I will be your host for this evening. For those who are new, VIVA is a charity focused on saving the lives of children with cancer through excellence in research, medical care, and education in Singapore, Asia, and beyond. Every year we organize educational exchanges amongst doctors, nurses, and other medical professionals, most notably through our annual St. Jude Viva Forum. Since we're in the midst of a pandemic, we've been organizing webinars to continue sharing the latest developments in research and the treatment of pediatric cancer among the medical community. So tonight, we're pretty honored to have with us a very distinguished panel. We warmly welcome our main presenter, Dr. Arvind Kumar Sinha, our panelists, Dr. Miriam Kimpol, Dr. Trisha Alcasabas, and Dr. Saw Yen, and of course our chair moderator, Professor T.C. Kwok. So thank you so much for generously lending us your time and expertise tonight, and we hope for a very fruitful session. And it is also with great pleasure for me to introduce our chair for this evening, Prof. Kwa, who needs no introduction. He is a senior consultant at the Division of Pediatric Hematology and Oncology Unit at the National University Hospital of Singapore. He is also an associate professor at the Yong Lu Lin School of Medicine at NUS. He has been trained in pediatrics since 1975 before training in hematologist-oncologist under Professor Wong Hock Boon in 1983. Prof. Kwa is also the recipient of the National Medical Excellence Awards Outstanding Clinician Mentor Award in 2013. And without further ado, I'd like to turn over the floor to Prof. Kwa, who will introduce the webinar as well as our speakers for tonight. Over to you.
Okay. Yeah, thanks very much, Teresa. I'm so glad to see this wonder of Zoom. Yeah, I can see quite a few Filipina faces. Yeah, and my friends across the island. Yeah. So yesterday I was just invited for a dinner by my son and daughter-in-law for my 70th birthday. So I just recall those days when I was training initially as medical students, then pediatric training and whatever. Yeah, in the era without ultrasound, before CT scan, before MRI. Now, of course, with the PET-CT scan. Yeah, so all these are wonderful things which show us what's happening in the bodies of our patients. But I find that the PET-CT is sometimes quite difficult to interpret. So I'm very glad that we have my friend Arvind. Yeah, he has been with us for many years. So I would, whenever I'm stuck, I would go down to his office and look at the computer screen. Yeah, showing different colors. Yeah, green and blue and yellow and orange and red and white. Yeah, so he would try to decipher this for me. Yeah, so we are glad to have him because Arvind is one of the doctors. Arvind, what do you call yourself? Not nuclear physician, right?
Yes, Pa.
Not a radiologist.
No, I'm not a radiologist. I'm nuclear physician, nuclear consultant, nuclear medicine consultant.
Nuclear medicine consultant. Okay, yeah. So he was trained in the Memorial Sloan Kettering Cancer Center, yeah, which has been consistently voted as one of the 2 top cancer centers in the US. The others, of course, are being the Anderson. Yeah, so he was there at the beginning of PET-CT scan. Oh, yeah, so PET has been around a long time. CT has been around a long time. So it's, I think, only about 20 years ago that they became a common practice to combine them together, and we can see that they are very useful. Yeah, so I'm glad he's here to help us to decipher all these different colors. Yeah, and then I would pass over later, to the two lovely ladies, Miriam and Tricia. Yeah, Miriam was trained in New York City, then he went back to Manila and then came to join us in NUH. Then Tricia was trained in Detroit. Yeah, went back to Manila, came to NUH for a stint, then went back to Manila, Philippine General Hospital. Yeah, and I hear that she's doing excellent work there. Yeah, so with this brief intro, I would let Arvind take over. Arvind, go ahead.
Okay. Hi, good evening from Singapore. I'm Arvind, one of the nuclear medicine consultant, not radiologist. And today I'm going to talk about the role of PET metabolic imaging in the children cancer. I love to answer the question rather to present some slides. But today I'm going to talk more on basic stuff of PET and then few applications for the pediatric cancers. Okay, next slide. So this is actually, you can see there is two pictures on this slide. There is one left-hand side and right-hand side. Left-hand side looks messy, and this is the real first PET scanner developed in 1950s at Mass General Hospital. And it is designed to scan brain without CT component. You can see the box-like structure around the patient's head, and it is a detector to detect the radiation coming from the brain. On the right-hand side, you can see that this is a modern scanner. It's called hybrid scanner. Both anatomic imaging modality, CT scan, and metabolic imaging modality, PET scan, fused together in single gantry. Next slide. If you look at the cross-sectional anatomy of the PET-CT, hybrid PET-CT, you can see clearly there is a two component on the left side. One is CT and one PET. And both are very close each other and separated with the lead lining. And this scanner is designed to do a scan within 6 to 10 minutes maximum. The benefit of the hybrid scanner is there's two main advantages with the only PET scan. First, before the 2001, only PET scanner available all over the world. From 2001, PET-CT invented by Prof. David Townsend, and it was installed in Sloan Kettering, Mayo Clinic, Pittsburgh, and Munich. So the benefit of this one is the scan time reduced, because earlier when the scanning was done only with the PET scan, we need to do a transmission scan. And it took about, it was taking about 45 minutes only transmission scan to make a body attenuation mapping. After that, PET scan. So total around 1 hour time involved in the only PET scanner. Currently, with the transmission scan is replaced with the current CT scan. It is taking only 2 to 3 seconds, not minute, 2 to 3 seconds to do an anatomic mapping from head to mid-thigh. And the scanner will do, the PET scanner will do only 5 to 6 minutes. So total scan time is currently with a normal size person is 6 minutes to 10 minutes maximum for the tall patients. Second benefit, can you next slide? Next slide. Okay, if you look at this image, this is the PET. What is the image of hybrid imaging? In this slide will, on the left-hand side, only PET images. You cannot see the CT component. And with the problem with the PET scan only, it is difficult to pinpoint localization of any activity in the body, whether it is coming from bone or soft tissue or coming from a problematic area like head neck area where the complex organ and many structure there. It is difficult to define the area, whether it's coming lymph node, salivary gland, tongue. then we need, so it is like a satellite image. If you look at this, is on the right hand side, this is a satellite image of the United States. You can see the clouds, but you cannot pinpoint where the cloud is hovering or is flying, whether it's a Florida area, is a high dense cloud, or a white cloud in the Texas area. So it's difficult to pinpoint exactly where the metabolic activity is coming. Next slide. If you look the CT scan, you can look the boundary of the United States. You can see the county of the, but you cannot see the black cloud. But if you fuse the satellite image with the map, next slide, you can see the pinpoint image of the activity. For example, you can see on the right-hand side, there is a triangulation done on the paravertebral spinal area on the left side. You can see the activity is coming. If you look on the CT component, it is difficult to say it is coming from soft tissue or the bony structure. So the main benefit is pinpoint localization of the metabolic activity, and also there is a reduction in the scan time from 45 minutes to about 6 to 10 minutes maximum for the new hybrid scanner. Next slide. Okay, this one is a normal PET scanner, a scan of the body. On the left-hand side is called MIP image, is a compressed image of the entire metabolic activity coming from the body. You can see clearly the myocardium, kidney in one rotating image. And this is the area where we can triangulate the area of the metabolic activity. Second image is a low dose CT scan where you can see the organ, but it is not contrast enhanced. Third one is pure corrected image of the whole body. You can see the only PET image on the, if you look at the fourth image is a fuse image, both CT component and PET component is fused together. You can see all the boundary from where the metabolic activity is coming. Last is scan is, last image is called non-corrected image. We use this image as non-corrected image in case if the patient has any metallic hardware in the body, like in this metallic rod in the spine, hip prosthesis, knee prosthesis, then we have to look, is the real activity is coming from the body or the only attenuation artifact. With the help of this non-corrected image, we can tell clearly where the activity is coming. So this is very useful for the patient who has a metallic hardware or prosthesis type thing inside the body. Next one. So, okay, look at the PET scanner. I'm not talking at the cancer at the moment. If you look at the PET scanner application in the patient management, there is a 3 area we can use, widely used for the PET scan. First is cancer, oncology. If you go in any nuclear medicine department where the PET scanner, about 98 to 100% work done for the oncology work, for staging, restaging, recurrence, like that. Second application, PET is approved from FDA about the dementia evaluation, neurodegeneration, Parkinsonian disease, Alzheimer's. We use a different type of plaque imaging biomarker. We use that one. Sometimes we use PET scanner FDG for the epileptic focus localization. The group of the patient, when they are not responding with the medical treatment, for surgical point of view, we have to do the PET scan to look at the focus of epileptic focus in the brain for resection. Third one is cardiology. We use rubidium, a biomarker, for the ischemic evaluation. So these are the 3 areas where we use the PET scan for the patient management. Miscellaneous, we also use a PET scan in bizarre type of a referral form. For example, if a patient has a pyrexia for unknown origin and CT MR is negative to localize the infective focus, then we can use FDG PET scanner to localize the infective focus. Because what happened in the infective focus, there's an activated form of polymorphonuclear cells is very high density, and they consume in activated form, they consume plenty of glucose, and at that point we can detect that area of infection. Second, we can use the PET scan for the prosthetic loosening evaluation, like a hip joint replacement, a loosening, knee replacement loosening, a spinal rod screw loosening, we can use PET scan. Sometimes plain radiograph, MRI or CT scan not very, cannot tell the loosening, but PET scan can tell you, because there is a, if any loosening, there is always inflammation around the metallic hardware, and you can see there's a curved linear pattern of uptake in the around the metallic hardware. So these are the application for the patient management. Next. Okay, so now the next one is, what is the capability of PET scan compared to CT and MR? If you do a CT and MR, you can see the any organ size, shape, dimension. You can look at the local invasion of any tumor, and you can tell the enhancement of the contrast. But PET scan will not tell this thing. With the PET scan, we can check the any organ, tumor, lymph node, metabolic activity, and other things. So we will talk in summary about this thing. So with the PET scan, we can check the metabolism of any organ and tumor. With the help of different biomarker, with the glucose, we can check the tumor metabolic activity. With the amino acid, we can check the any with the sum of the tumor, especially for the brain. Fatty acid biomarker, we can use this biomarker for the brown fat metabolism. Also, we can use this biomarker for the liposarcoma. PET also used to look the perfusion of any tumor or any organ. For example, ammonia biomarker is used for the cardiac viability study. Next one is a hypoxic tumor. We can use F-MISO biomarker to look the hypoxic tumor, especially for the head and neck cancer. Next one is the receptor, receptor containing tumor like neuroendocrine tumor. They have a high density of somatostatin receptor. We can use gallium-68 proton knock to look at this tumor. Second is PSMA, is called prostatic surface membrane antigen biomarker used for the prostatic cancer. So we can look the tumor receptor. These all things cannot see with the CT or MR. We can check with the PET scan cell proliferation, like it also causes it also called DNA probe, F-thymidine, mainly used for the lung cancer, sometimes in the brain tumor too. Next one is apoptosis. We can see a tumor dying actually. With the PET scan, we can check the tumor death with the biomarker is called F18 annexin. The last but not least is angiogenesis. We can use copper 68, 64, VGRF, vascular endothelial growth factor, especially those patients who's getting anti-angiogenetic chemotherapy agent. We can check there the angiogenesis is decreased or same or increase with this help. So these are the minimum. There are many things are in the pipeline regarding the receptor development, receptor binder biomarker development, and these are coming in the future years actually. Especially these are the brain area is mainly a lot of things are going on at the moment. Next slide, please. Now we are talking about the metabolism. Metabolism. If you go in any nuclear medicine department, the glucose is the main workhorse for any tumor imaging. The reason behind it is that the tumor, most of the tumor in the body consume plenty of glucose. And there is one study done in the University of California by Sam Gambhir, is one of the pioneer in nuclear medicine. He did a study with the biochemistry attending, and they did analysis of the energy production in the tumor cells and the normal cell, and how they attract glucose molecule inside tumor cell more than the normal cells. So they did first analysis about the normal cycle. So normal cells in one cycle of the glucose, they produce only 30 ATP per cycle, whereas the cancer cell produce only 2 ATP. Their energy demand is very high, but they have inefficient energy production. Next slide, please. This is the sketch of the vascular compartment and the tumor cells. So if you look at the tumor cells, there is in the lateral side of the tumor cell near the vascular compartment, there is a red dots. And you can see there is this is called a protein, glucose transporter protein, is GLUT1 to 5. The density of the glucose transporter protein on the tumor cells is very high compared to the normal cell. So what happened when we inject a glucose analog is not real glucose, because this glucose is a little bit changed because we remove the hydroxy ion from the glucose and replace with the fluorine radio molecule. So when we inject the glucose analog in the body, this protein, what happened, understand this is a glucose molecule, so they transport this molecule inside the cell with the help of the glucose transporter, and the density is the glucose transporter protein is very high on the tumor cell. The sucking power of the glucose compared to the normals is very high. So what happened when you inject, most of the glucose go inside the tumor cells. So once the glucose analog trap in the tumor cells, with the help of the hexokinase is converted into the FDG6 phosphatase, and this is the molecule is in polarized status. So in that status, it will not go in further metabolic pathway like glycogen, glycolysis, or HMP shunt. So it's stuck in the tumor cell, and the fluorine part of this glucose analog start decaying inside the tumor cells, and it emits on the decay process, it emits the positron, and then it is detected by the PET scanner, and with the help of the computer, it makes the image. Next slide. Next slide, please. Next slide. Yeah. Regarding the applications, this is the application for the adult. These are the main application for adult. Next one. This is the pediatric application. They are the 6 application at the moment. We are using the PET scan left and right, but the 4 is well defined: lymphoma, neuroblastoma, bone tumor, and soft tissue tumor. These 4 areas is well understood. But regarding the Wilms tumor and central nervous system, the status is still not clear in the beginning, but we can use PET scan in the recurrence of the Wilms tumor or staging in high-risk patient for this one. Next slide. Regarding application of the PET scan in the cancer, if any cancer patient coming to oncology department, there's 5 things in every oncologist's mind. First is diagnosis. Correct diagnosis needed. Second is proper staging need to be done for proper treatment planning, whether we want to do a radiotherapy planning, detection of recurrence, and last but not least, prognosis and surveillance. So where the PET scan is fitting in this all 5 area. First, diagnosis, we never use PET scan as in the diagnosis of any tumor. We can use the PET scan in the diagnosis when the tumor of unknown origin. For example, patient came in the department with the lymph node swelling in the neck and biopsy proven some adenocarcinoma and CT MR is negative, then we can use the PET scan for unknown primary. Sometimes we use PET scan to differentiate between tumor and non-tumor. For example, a patient has a solitary pulmonary nodule in the lung. He's not a smoker, but we got some 2 centimeter size of pulmonary nodule. The patient wanted, or doctor wanted, non-invasive procedure to diagnose it is a cancerous or non-cancerous. Then we can use this PET scan. And also, third one is very important. We can use PET scan for determination of the biopsy site, because chances of sampling error is high if you are not looking at the active tumor site for the biopsy. Staging, highly recommended. Most of the patient, most of the cancer patient, PET scan is highly recommended for staging for TNM, grading the malignancy, and characterization of the tumor. Treatment planning, it depends on the radiotherapy, what you want. If you looking, patient is going for radiotherapy, then we can do a PET scan for treatment planning. Detection of recurrence or residual disease is also highly recommended, or re-staging in the case of recurrence is a highly recommended PET scan for the cancer management. Regarding prognosis or surveillance is depend case by case, is not always recommended, but in some case, the high risk patient, and symptomatic patient, we can use PET scan for surveillance or prognosis. Next one. So now question, can we do a PET scan for, if any patient coming for the, coming for management cancer patient, do we want to do a PET scan? Next slide, please. Or if a patient has unknown origin, cancer, only lymph node is positive, you want to do exploratory surgery and it become negative, or you want to do a PET scan. Next slide, please. So we start with some application of PET scan in the different type of cancer. First is lymphoma. Lymphoma, actually what happens, the lymphoma is a very glucose average tumor. Most of the tumor consume plenty of glucose. So in the US, the first FDA approved indication was lymphoma and melanoma at that time in 2001. So lymphoma, we can use PET scan as a pre-treatment staging. We can use therapeutic response, mid-cycle therapeutic response. We can use PET scan for restaging and recurrence. We can use any residual mass is viable or only necrotic soft tissue mass. Follow-up PET scan is not recommended, but you can use in high-risk patients. Next slide. This is the one study done with the by the WHO, and about total number of the patient is close to 800, and they found most of the subtype of the lymphoma has very high avidity, close to 100%. Very few lymphoma has lower affinity for the glucose, and they are the rare lymphoma subtype. Next slide, please. And this same study compared with the Japanese and European people, and their result is more or less similar pattern of the WHO. So PET scan is highly recommended in the management of the lymphoma. Next slide. So regarding sensitivity is about 94% as per JNM, but I will call is close to 98%, is very close to 98%. Very highly specific, 90 to 100%. Next slide. This is one patient of lymphoma. You can see this is the PET scan down on this patient, and you can see the bulk of the disease below the diaphragm in the main mid-abdominal area. And next slide, please. Yeah, and this is the PET scan done on the same patient after javelin treatment, monoclonal antibody therapy with the Y90, and you can see there's the only residual activity seen in the paragastric area. In the rest of the disease, both above and below the diaphragm is melted down. So this is one example of the PET scan for the treatment response. Next slide. So next cancer is in the children is neuroblastoma. So if you look at neuroblastoma, in nuclear medicine, the imaging can be done in the 3 biomarker. The first is MIBG. It can be done by iodine 123 or iodine 131. And it is the gold standard. MIBG is still the gold standard for the neuroblastoma imaging. Next is FDG gallium DOTA. It is a peptide imaging to bind the somatostatin receptor. Many studies done and compare with the MIBG, and they found they are very close. They are very similar sensitivity for the neuroblastoma tumor. Indium 111 octreotide scan used long ago in 1970s. These days they are not using because image quality is not very good like PET scan. So the only 2 things running at the in the medical field is MIBG and PET scan. Currently in Sloan Kettering, they started MIBG iodine 124 PET scan. It is not a gamma scan, iodine 124 PET scan, and the sensitivity is very, very good compared to the gallium DOTA NOC or MIBG. Next slide. So what is the clinical indication for PET in the neuroblastoma? We can use the gallium DOTA NOC study for the staging. We can use this for after surgery follow-up. We can use after the therapy, chemotherapy, or triad or interferon therapy. We can take the decision on PRRT, the peptide receptor radionuclide therapy for the neuroblastoma, and we can also use the same for the response evaluation after a PRRT therapy. Prognosis, it depends, is the patient, if you want to do PET scan, generally it can done for the high-risk patient when the bone marrow are involved. than when we can use PET scan, but it's still questionable. Next slide. This is the one case here, neuroblastoma case. You can see the right adrenal mass and PET scan is positive, and rest of the body is negative. Next slide. And this is the other patient has a neuroblastoma, and you can see the left adrenal is a big, huge mass with necrotic tissue, black here, and there is a metastatic deposit in the right inferior pubic ramus. It was negative on plain CT with the contrast. So PET scan can detect the bony metastatic disease better than the CT. In the early bony metastatic disease, PET scan can detect more, sensitivity is more compared to the only CT scan with the contrast. Next slide. Next one is a bone tumor. There's two tumors in the children, is osteosarcoma and Ewing sarcoma. So next slide. So this is the osteosarcoma is the most commonly primary malignant tumor of the bone. The current treatment is neoadjuvant therapy and surgical resection. Role of imaging for the nuclear medicine to evaluate, first we have to look the degree of the local extension, preoperative planning. We have to look the staging, any skip lesion around the bone or distant metastatic disease in the lung or any bony involvement. We also use PET scan, the assessment of the neoadjuvant therapy and chemotherapy. Next slide. In nuclear medicine, there are the four things we can use, general nuclear medicine. One is bone scan, we can use for the skip lesion. PET scan used for the both soft tissue and bony lesion, we can use PET scan. Thallium and BB was used in 1970 because thallium worked on sodium ATPase pump. BB was also used for the, because the BB has an affinity for mitochondria, and any cancer cell, the mitochondria density is very high in any cancer cell. So they have affinity for the BB. So these last two one was used long ago in 1970s, but PET scan, bone scan is highly left and right used for the bony tumor in the children. Next slide. If we're looking at the response therapy from response of the neoadjuvant therapy, if you look the morphological imaging like plain radiograph, the good response is called when the size is decreased. Calcification of soft tissue is called good response. Bad response called when the tumor size is increased, and any sign of invasive appearance in the plain radiograph is called poor response. If you look the MRI, if any necrosis in the image, hemorrhage, fibrosis or granulation tissue in the scan is called a good response. Poor response in MRI called when the persistent or increased peritumoral edema on T2 images or increased tumor volume is called poor response. Next slide. Regarding the purpose of imaging, PET is used mainly for staging in the bony tumor, can be function as non-invasive assessment of the response to the chemotherapy, like a neoadjuvant therapy, and provide preoperative prognostic and survival information. If the SUV is high, many sites of involvement in distant metastatic progresses is not good. So PET can tell you about the prognostic and survival information in the bone tumor. Next slide. Rhabdomyosarcoma, we're talking about soft tissue tumor. These are the area where we got the rhabdomyosarcoma. Next slide. The head neck is the commonest site of the rhabdomyosarcoma. Next slide. The role of the PET scan in the rhabdomyosarcoma is initial staging. We can use PET scan recurrence and neoadjuvant therapy. If the ACV in mid-cycle decreased by 50%, is supposed to be called a good response. Next slide. This is one of the case has an alveolar rhabdomyosarcoma, and CT was negative. We did a PET scan on this patient, and we found both breast was involved in 14 years old girl, and the spine, thoracic spine is also involved. It was negative in the CT scan finding. Next slide. Limitation, regarding limitation of the PET scan in the cancer imaging, false positive, you can get the false positive in inflammation, trauma, or sometimes healing process also cause a false positive information. False negative in some cancer where the glucose consumption is not good, you will get the false negative information. Regarding the spatial resolution, PET scan is difficult to detect the lesion if less than 5 or 6 millimeter in diameter. it's difficult to detect that area because the density of the photon in a small area is low and detector cannot detect the small lesion. Next slide. Regarding the radiation burden of the PET CT, this is the main topic this day, and this is the radiation burden written on this slide of the adult. If you look at the PET scan and CT, there's 50% radiation coming from the PET part, 50% coming from CT. But with the new advanced multi-detector CT, they reduce the CT radiation burden by 20 to 50% actually currently. But the radiation burden from the PET cannot be reduced due to the dose. We have a fixed dose. We cannot reduce the dose because sensitivity will decrease. So if you look the children radiation burden is total in our department currently getting about close to 5 millisievert. And if you look the chest X-ray radiation burden is 0.1 millisievert. And background radiation every year in the incubator, we are getting about 2.5 millisievert per year. So in children, we are getting about 5 millisievert. If you remove the CT component with the MR, the radiation burden will be only 2.5 to 3 millisievert. So half of the radiation burden will decrease. But with the current scanner, total radiation burden in children is getting 2 to 4 millisievert maximum with both PET and CT. Next slide, please. Next slide. Next slide. This is that was my last slide. Any question and concern, you can ask me.
Okay, thanks, Arvind. Tricia, would you like to go on with the Q&A?
Hi, Dr. Arvind. Thank you so much for an excellent talk. Most of the questions from my colleagues in the Philippines you tackled it in your lecture. Thank you so much. But one question that I have is with regards to bone marrow involvement.
Yes.
Can you use the PET CT scan to determine if there is bone marrow involvement, for example, for rhabdomyosarcoma sarcoma or lymphoma? Thank you.
Yeah, this is a big question actually. Everybody asking about the bone marrow involvement can be diagnosed with a PET scan. Problem is that the glucose affinity for the bone marrow is always fluctuate with the time, actually, age. And there is always uptake in the bone marrow. So if you look at the literature, there are the many literature published. They are saying about 40 to 70% sensitivity of the PET scan in the bone marrow evaluation. I will not depend on the PET scan finding in the bone marrow. I will prefer to, I always in the lymphoma round, I always told my colleague better to do trephine and look at the bone marrow biopsy to look any bone marrow involvement. But if by chance, if the uptake is very high, cancer cells density is very high, then PET scan plays little bit role. But still the sensitivity is 40 to 70% is a big range. So it's not very good sensitivity at the moment with the FDG.
Thank you. Just one more question because there are several questions already in the box. What about doing PET scan after radiation treatment to see treatment response?
Yes, very good question. Yeah, radiation always causes inflammation around the tissues. Always there is some body defense mechanism working around the tumor treatment site. And these are the polymorphonuclear cells. When activated at the site of inflammation, they consume plenty of glucose. If you look at the literature, they are saying if you want to look at radiation inflammation or residual disease, better to do 12 weeks, 3 months. But I look here, I did many times here in the anyways. I think 2 months is adequate time to look at the inflammation versus a residual disease. 2 months, 8 weeks enough. And we do sometimes dual point imaging. We scan the area where the radiation given, area of interest, and we do again a scan after 2 hours from time of injection. So one scan done after 1 hour, after the time of injection, and second scan done after 2 hours. So if the ACV is decreased, most likely 99.9% is inflammation. If it's increased, we ask to do a follow-up scan after again 2 months, and then see whatever the activity is coming will be real. But we resolve this issue within 2-point imaging. It's called 1 hour, 2 hour imaging.
Thank you.
Okay.
Arvind, if I may add something,
Sure.
the context of the scan is so important.
Yes.
Yeah, how soon do you do the scan after the last chemo, and also the timing in relationship to administration or GCSF, then the bone marrow would all light up. Yeah.
Because if you give a GCSF, it effect lasts 2 weeks at least, minimum 2 to 3 weeks. And if you want to finish a chemo, you give at least 1 to 2 weeks at time, and we can tell you how the chemo works on the patients. Regarding GCS, I always recommend better to do after the scan. But if you're not worried about the bone marrow uptake, then is no problem at all for us.
Okay. Okay. Just one thing. As I said, I was 70 years old 2 days ago. So the Alzheimer is coming on. I forgot to introduce Sui Yan. Yeah, Sui Yan is the head of pediatric oncology across the island in the KK.
Sure, sure.
Sui Yan, yeah, do you have any comments or any other things that you want to share?
Prof, happy birthday.
Thank you.
You are 1 year younger than my mother. So, yeah, and you're still so active, really example for all of us. So, thanks Arvind for the very nice presentation. I think we have already a few questions asking about the PET-CT as a modality for evaluating brain tumors or brain metastases. Yeah, would you comment on that?
Yeah, there are a few biomarkers currently available in the Singapore. We can use it's called F-choline. We did about like 100 study, close to 100 4 years ago, and we found that it will give a good information regarding the residual tumor after the radiation of chemo. So we can tell with some biomarker like a choline. FDG is not good for the brain tumor, whether it is recurrence, but we can tell this one is not. It takes time to read the scan with the FDG. Choline is very easy because if you inject a choline biomarker, it will not go in the brain. It will brain looks blank if you do choline PET. And if a patient had tumor, there is always uptake around the tumor, and any residual disease you can tell with that one. So choline plays a very important role. Some of the amino acid thymidine also used for the brain cancer. Singapore we not started at the moment, but they are planning to start this one biomarker amino acid imaging for the brain, and most likely we will start this year, in the coming year, because due to COVID this year a little bit down, but next year we are going to start a different biomarker better than the choline. It's called thymidine for the brain tumor.
Okay.
Just one little comment before I pass this to Miriam. You see, the problem, when we interpret the bone marrow PET-CT, if it is, of course, due to the overactivity of the marrow, the increased activity should be diffuse. Yeah, but what I find in that, if you have a lymphoma or other tumors that are spread to the bone marrow, it is almost always patchy. Yeah. So from the pattern in involvement, you can have a good idea.
Yeah. Should I tell something about this one?
Yes.
Patchy pattern, yeah.
Yes.
Yeah, this if you look at the bone marrow, there's two patterns always seen. If you give a GCSF and post-GCSF effect, you can see the diffuse pattern of uptake in the axial skeleton and proximal appendicular skeleton. If there is a patchy uptake, of the, especially in the spine, sometimes you get a patchy uptake of especially FDG, then it's difficult to diagnose whether it is coming really from the tumor or reactive changes is difficult. At that point, we always advise to do a MR of the spine to see how's the marrow status. Not with the PET. The PET scan is not very sensitive from glucose point of view. So I will not recommend, if we are saying it better to evaluate with the MRI is better. Patchy is always problem for us in the spine especially.
How often can you safely order PET CT for disease surveillance?
There's a surveillance is always question whether we order PET scan or not. First thing, if the surveillance in high risk patient or symptomatic patient, we can order a PET scan on 6-month basis. If first 2 PET scan is normal, then you can do yearly, is okay. But there is no recommendation so far to use PET scan as surveillance.
Okay. Number 2, how good is the CT in a PET CT?
Yes.
In what circumstances would an additional anatomical imaging be necessary, whether it's CT or MRI?
Yeah. I will tell you first thing, most of the PET center, the patient in coming in the department for PET scan, mainly this group of the patient is had already CT or MR done or diagnosis done. This group of the patient coming to the department only for a staging point of view or recurrence or re-staging point of view. At that point, it depends if the referring doctor wants a contrast CT, a diagnostic quality of CT, we can do, because every PET scanner, hybrid scanner, the CT scan has a capability to do a diagnostic quality of the CT component. The problem is that we don't want to increase the voltage of the CT scanner, is called milliampere, to decrease the or minimize the radiation burden from the CT component. So if the patient has already CT scan done and referring doctor don't want, not interested to do a diagnostic quality, we always do non-contrast low dose CT scan, and this CT scan is not diagnostic quality. It can look very clearly organ to pinpoint localize the metabolic activity. But every PET scanner, PET CT scanner can can do diagnostic quality of CT scan, depend what you want. But if the patient has already had CT scan, there is no need to repeat again because it costs more. It costs more radiation burden to the patients. So this is like that.
Okay, thank you very much. Our lovely okay, now we can see you. Question number 3. Please comment on the PET MRI as a new modality.
Yes, Prof. What is your question?
PET MRI, please comment.
Yes. PET MR is a big question, actually. Big question. Yeah, the PET MR. If you look at the PET MR, of course, there is always question about the radiation burden to the patient. So if you do a PET CT, there is a 2 component of radiation. One component is coming from PET, one component is coming from CT component. To minimize the radiation, you can only minimize from CT component. You cannot minimize the radiation burden from the PET component. MR is very good. PET MR is very good if you're looking for soft tissue tumor, if you're looking for head neck cancer, and also the parents who is concerned about radiation burden, we can do. But there is a cost of this concern. If the patient is coming for the every month like a PET scanner to look at the disease process or some of the chemotherapy is running, then there is a concern of radiation because you are doing about 4 to 5 PET scan, especially in Sloan Kettering Pediatric Center. They do a lot of a PET scan for the pediatric group if they're getting chemotherapy. So in this group of patient, PET MR is very good. But if you're doing a 2 or 3 PET scan per year, PET CT is not bad because the current CT scanner give you very low burdens, radiation burden is equivalent to 2 to 3 millisievert maximum. And it is not bad because you have to look benefit and risk. The problem with the PET MR, the scan time. The scan time is almost like an old PET scanner, about 45 to 50 minutes. Second thing, the gantry is very small or claustrophobic. You need to sedate the patients. Third thing is cost. Cost is very high. If you do a PET CT, its cost is 2,000 something. If you do a PET MR, it's cost $5,000 in Singapore. The cost of the machine also very high in PET MR. It costs about $10 million one scanner. That is why the cost of the PET MR is very high. So it depends what you want. If you want to minimize the radiation burden, I'm very concerned. Of course, we need to do the, especially for the soft tissue tumor, head neck cancer, and also the soft rhabdomyoid sarcoma type things. We can do the PET MR. It's not a problem.
Okay, 3 more. What SUV is significant more than 2?
Earlier, when the PET scan started, always there's a, in 2003, they said if the SUV is more than 2 or more than 3 is a positive. Less than 3 or less than 2 is not positive, but it is wrong this day. It depends how the pattern of uptake. We are not looking number. We are looking the number when it's more than 10. This means aggressive tumor. Very prognosis is not good in this group of the patient. But if coming about less than 10, about 1.5, 1.8, some of the lung tumor is coming, SUV is 1.8, biopsy is positive for the solitary lung tumor. So SUV doesn't mean at the moment, but high number, double digit, always give you the data the patient has a very aggressive type of tumor and chances of prognosis is not very good.
Okay. One more. When can PET CT be requested post-radiotherapy? After 2 months?
After that radiation, actually, is ideal is 3 months, but in our hospital, we are doing it 2 months is enough time to heal the inflammation of the radiation.
Okay, last one, I think. What does it mean when a lesion appears on PET CT but not seen on the concomitant CT scan?
Yeah. In the early metastatic disease, early part of metastatic disease, in the process of metastatic disease, early part, what happened? The anatomic configuration is still same. If you do a CT and MR, the anatomy is not distorted. You will see very normal appearance of tissue. So the problem is that if you get this type of PET CT is positive and normal CT and MR is negative, just do a follow-up scan after 2 months and look the activity, how is the activity. If activity is same, not increase SUV, configuration is same, there's no need to proceed anything for the biopsy, but SUV is increased, then you have to do biopsy of that area. So early part of the metastatic disease process, CT and MR is negative, especially also seen in the bone scan. Bone scan is positive, but there is no CT component, any abnormality in CT scan. So it always happens in the early part of metastatic disease process.
Okay, so before we go off Zoom, are there any comments from the panelists or anybody from the audience?
Hi, Prof. I think there are 6 more questions.
Yes, go on. Yeah.
So I think, so do you mean for all peds PET CT, do you recommend to do with low dose non-contrast CT fused with PET?
It depends on what you want actually. What you really want CT contrast, we can do. Is not a problem at all. We can do this one. There's 2 questions actually. If the patient has already CT done, there's no need to do contrast PET CT. But if there's nothing done, you can order a PET CT with the contrast. Is not a problem, and we can report the contrast CT together actually.
Okay. I think generally we would prefer a fused images because of you need to localize where the lesion is. The next one is lymphoma. Will PET scan post-treatment be recommended for monitoring residual disease?
Yeah, if the patient has a big site tumor like a mediastinal mass, we can use the PET scan for the residual mass. Of course, we can use. Is because we have to look the metabolic activity. With the CT, MR, you cannot tell. Only PET scan will demonstrate what is the residual tumor volume inside the mass.
Yes, so I think for our patients, sometimes they have a residual enhancement that we monitor over time, and they just decrease over time and then eventually resolve. So the next question is, how do you deal with FDG with small cervical lymph nodes in lymphoma of treatment?
Can you ask me the question again, please? It's not very clear.
So these are at end of treatment, if you have a FDG with small cervical lymph nodes, the patient who was treated for lymphoma.
After the end of the treatment, and is still some positive lymph node in cervical area, you're saying, right?
Yes. So would you be able to differentiate whether this is inflammatory? I think that is
no. It's very difficult. First thing is very difficult to differentiate, but we have to look the size, shape, fatty content. Is still the fatty hilum intact or not? Then we can tell is infectious or. But very difficult to accurately tell it is due to lymphoma or infection. Biopsy is the only route to diagnose 100%. The head neck
disease. Do you have any comment?
A common problem that we see would be mediastinal lymphoma, especially Hodgkin. It's well known that when you finish treatment, often the mass is still there. So with the pre-PET-CT era, we sometimes will get the surgeon to biopsy. Of course, that's quite a big procedure. Yeah. So then in this instance, the PET-CT comes in very helpful. Yeah, so we have seen a few kids where the mass is there, but the PET-CT is clear. And what is very interesting is that if you, after that, I stop doing the PET, I stop doing the CT, I just do a chest X-ray because you can see the mass. And you can practically see the mass melting away over months. Yeah. So then for me, if the mass is still there, not surprising, especially if it is a Hodgkin, especially if it is nodular sclerosing. So what is left is not the tumor cells, but the fibrosis. Yeah, so we'll just if there's a chest X-ray, can see easily. So that is a very safe way to follow up the child. Okay, I also see a question from Rizky in Cipto in Jakarta. Okay, what is the tolerable time interval for 2 PET-CT examinations in pediatrics? I mean,
yeah, it's not a problem to do a PET scan 1 month apart is not a big deal actually. I have seen the Sloan Kettering after chemo 20 days they did, after 20 days they do. But I advise it better to do after 1 month.
Okay, yeah. I think that's one question which is probably for me. Okay. Do you have experience in LCH PET imaging? Since some articles say it is able to detect more lesions than routine skeletal survey or bone scan.
Yes, agree.
Yeah, I think that is not important because if it is a LCH, it's more important to look at other features, not whether it is wrist organ or not. So whether you have 3 bones affected or 5 bones affected actually doesn't affect your treatment. Yeah. But what is the interesting is that it differentiates between LCH lesion that is quiescent versus one that is active. Now we know when we treat LCH, for example, those with soft tissue masses, yeah, after you finish your treatment, the mass can still be there, but the cells are already dead, quiescent. It's a bit like Hodgkin. Yeah, so then if other features show that the LCH itself is not active, I will just leave it alone. And how do you know whether the lesion is active? 2 scenarios. One is a case where LCH cells will produce cytokines to cause inflammatory blood picture like anemia, thrombocytosis, neutrophilia. I find it to be helpful. Yeah, but some of them don't. Okay, Abhi, next question for you. from Pfizer.
Nice.
Yeah, do you see that ability of PET-CT to evaluate small lung metastasis?
How small they were looking actually? How small? The small size means is a less than 1 centimeter, more than 1 centimeter. So
yeah, I mean maybe the point is to compare the PET-CT just with the CT scan alone.
okay. The question here, because what happened, the PET-CT resolution with the newest scanner is coming about 5 to 6 millimeter in diameter. The PET scan pick up the metastatic disease in the lung coming from osteosarcoma or soft tissue tumor. They can pick up the metabolic activity size is more than 8 millimeter to 1 centimeter and above. But less than 6 millimeter is difficult to pick up by the PET scanner. It is beyond the resolution of the PET scanner. So size is important, especially a smaller size, but more than 8 millimeter, there should not be any problem with the PET scan. But some of the mucinous adenocarcinoma, small lung lesion, is difficult to pick up by the PET scan, even the size is more than 1 centimeter, because they consume less glucose.
Okay, I can see one last question. What is your opinion on sedation option versus non-sedation?
Yeah. Yeah, we are facing every day, because PET scan very important to keep quiet on the table. If a movement is a problem, then what happened? There is a misregistration of PET component with the CT, and it's difficult to read the scan. So sedation is very important, especially small children who cannot keep quiet. We have to sedate the patient to keep the patient quiet on the scan table. Is very important. Otherwise, the scan is suboptimal quality, and we cannot tell anything about the metastatic status or the tumor metabolic activity, because movement causes a lot of image degradation actually.
Okay, yeah. I have a question myself before I pass on to the ladies. Is it safe for pediatric oncologists to read their own PET-CT scan?
Yeah, PET scan need to read by the nuclear physician who trained in the nuclear medicine. It is not wise to read PET scan by anybody who is not done rotation or certification in nuclear medicine, because it needs some training for. It is not a bone scan. It is very different, and we have to define. So there is a special training for PET if you go in any training in nuclear medicine. So I will not suggest at all to read by anybody other than the nuclear physician.
Okay, thank you very much. Okay, I want to pass on to the three ladies, clockwise from the north, the eastern corner, which is Sui Yan. Yeah, Sui Yan.
Yeah, so Prof, luckily you asked the last question, because we all thought that after this session, we all will be able to read the PET-CT. So thankfully, that's not the case. We still have to discuss, with our nuclear med physicians. Actually, I wanted to also ask Arvind, do you routinely report the lymphoma scans using the Deauville criteria? And if the score is 3 or less, generally
we always use Duval score, because lymphoma tumor board. On Thursday we do the lymphoma tumor board. We used to have 4 or 5 cases to present with the PET scan. Michelle is leading the team, and she always asks about Duval score.
Correct.
I am not very happy with the Duval score, because there is some. It will not tell you exact tumor mitotic activity. It will tell you some inflammation after the chemotherapy too. Is a combined effect. But Michelle so we always follow in our hospital, we are always 100% following the Duval score. Is very important.
I think we have another question. we have another question in the Q&A, which is also something that my department discuss very often with the nuclear med department.
Sure.
Do you scan to the feet or just upper thigh? Because the classic whole body PET actually is just to upper thigh, unless we specify and request for head to toe.
Yeah. These are the question coming from oncologists, why we are doing mid thigh, why we are doing to head to feet actually. First time lymphoma, we always scan every patient from top to bottom, means head vertex of the skull to the feet. And if the first scan is negative below the thigh, we are not follow-up scan, we are not scanning. The other cancer, unknown primary, we top to bottom. Melanoma, we do top to bottom. Sarcoma, we do always top to bottom. So these are the 4 or 5 cancer. First time we always do. And follow-up scan, sarcoma, melanoma, we always do top to bottom. And recurrence case of any case of lymphoma, we do top to bottom. Is like that. Generally, the metastatic disease rarely see below the thigh actually, especially because especially in the bone, because in the thigh, the long bones, the red marrow is replaced with the fatty marrow, so the metastatic chances is very low, especially in distal appendicular skeleton. So it's like that, but in the high risk patient, we always do top to bottom. Actually, we did a study. We did one study here in 5 patients, and we keep the patient, especially the young patient, is in without blanket, and we did a scan. We got lot of uptake in the lower part of the neck, paraspinal area, and same patient of the second time when we did the scan after 1 month, we turned off the AC, we put the blanket and make him sweat a little bit. Did a scan, perfectly all right. But brown fat always happen, and especially younger patient is more. Sometimes old patient have been seen many times. It's not like that only young, but the percentage wise, brown fat activity is mainly seen in the children group. And it gives you a lot of problem for lymphoma evaluation, because it's difficult to differentiate between brown fat. Then we have to sit for another 45 minutes or 1 hour to play back and forth on CT and PET component to diagnose is a brown fat exactly, not lymph node.
Okay. Okay, Miriam.
No questions for you, Prof, but thank you for everyone. I was just discussing with Dr. Arvind about some of the challenges of PET CT that we find. So he has kindly offered these services to help anybody who has problems with their PET CT. He's willing to review all the
Yes.
messages with you.
Yes, 100% without free.
Thank you.
I will do free, and give me CD. I will sit with you. Tell all any external CD, not a problem at all from my side. Yeah.
Thank you.
Okay, thanks everyone. So we'll continue to pet our cats at the right time. Thank you.
Thank you. 9 p.m. Thanks a lot.
Good night.
That concludes our webinar for the evening. So thank you to everybody for joining us. So a big thank you to our presenters and our panelists, and also to our chair for the very informative and insightful session. And we invite everybody to help us to improve by filling up our survey form, and also to sign up for a mailing list to keep in touch and find out when we have our next webinar. Yeah, so thank you everybody for logging in, and we look forward to welcoming you in future webinars to come. So thank you and good night.
Thank you. Good night.
Hey, thanks, Teresa. Bye-bye.
All right. Bye-bye.
Bye.